Hello everyone and welcome to this HPS in-service webinar. I'm very pleased to bring this to you. My name is Catherine Bennett. I'm the Head of Marketing and Communications for Institutional Healthcare at EBOS Group. Today, our presentation is delivered by John Wilks, who is a clinical pharmacist at HPS Pharmacies Norwest. He'll be presenting on the topic of anticoagulant charting errors. This seminar has been pre-recorded, therefore we won't be holding any Q&A during this session. It will be purely a presentation only for on-demand purposes. And the content within can contribute to your CPD points. So on that point, I will hand over to John. Over to you, John.
Thank you, Catherine. So this webinar stems from a quality improvement project which is part of my honours degree with the University of Tasmania. The aim of this research is to investigate why patients are prescribed anticoagulation treatment in the orthopaedic setting, which are not supported by approved guidelines. Hence, I will review a number of cases focusing on the use and dosing of anticoagulation to prevent a deep venous thrombosis, DVT, or a pulmonary embolism, PE, collectively known as venous thromboembolism, VTE. My dual focus is on both the pivotal role of the pharmacist in the care of these patients and the pharmacist's interaction with the treating specialist. Recent Australian and international research has highlighted the positive influence a charting pharmacist can have on the error rates seen in hospital admission charts when compared to the same charting done by an admitting doctor. For example, Tong and co-workers reported that 70 completed by medical staff had at least one error, whereas the error rate for partnered pharmacists was only 3.7%. Research by Taylor and also Lim have reported similar advantageous outcomes when charting is done by a clinical pharmacist compared to an admitting doctor, with discrepancies and omissions attributed to the medical officer having the potential to cause more harm to the patient than those errors attributed to the pharmacist. Focus on the same themes: charting errors or discrepancies in joint replacement patients receiving venous thromboembolism prophylaxis, VTEP. As a necessary entree, it is important to have an understanding of the anatomical placement of a clot within the leg. Proximal DVTs are those which occur above the knee and involve the popliteal, femoral, and iliac veins, whereas distal DVTs are sited below the knee and involve the tibial, peroneal, gastrocnemius, and coeliac veins. The latter two are located within the calf muscle. This physical delineation is important because approximately 4% of distal DVTs will propagate upstream to become a proximal DVT. And proximal DVTs are more likely to cause a PE than a distal DVT. For clinicians, there is both certainty and widespread uniformity in international and Australian guidelines for the treatment of proximal DVTs. Similarly, most guidelines provide firm direction in the treatment of a distal DVT. For example, therapeutic guidelines states if a distal DVT is detected, it should be treated as if it were a proximal DVT or a PE. In like manner, the Australian Medicine Handbook makes no distinction in the treatment of a proximal or a distal DVT. The recent guidelines from the Thrombosis and Haemostasis Society of Australia and New Zealand is less directive in its advice. It states that uncertainty exists about the value of anticoagulation for distal DVT, which is true, but then, confusingly, says that distal DVTs may not require anticoagulation. Even less helpful are the recommendations from the American College of Chest Physicians in their 2016 guidelines which only offer weak recommendations based upon low quality evidence. This diminished uniformity of advice for the treatment of a distal DVT may be part of the reason I sometimes see patients receiving under-treatment for a distal DVT, and case study 2 highlights how prescribing falls short of the Australian guidelines. The critical question is therefore, are the consequences of these divergent guidelines clinically important? Simply put, the clinical significance of these equivocal guidelines can be seen in the potential medical consequences for the patient. Distal DVTs have a PE rate of 11.6%, and the PE mortality rate ranges from 3.9% at 1 month to 30% at 1 year. So, to the relevant cases. Case number 1. Mrs. JM, aged 78, had a TKR, total knee replacement, on the 6th of the 5th, 2021. So 10 milligrams Mane. 4 days later, a lower leg ultrasound revealed a 5 centimetre DVT, 13 centimetres below the perineal vein, within the perineal vein. The patient was changed over to a lower dose of Eliquis 5 milligrams BD because the VMO thought that her reduced EGFR required a low Eliquis dose. I calculated the creatinine clearance to be 38 mils per minute and advised the VMO that a full dose of Eliquis 10 milligrams charted. Case number 2. Mr. MR was aged 68. He had a past history of hypertension, gout, and elevated cholesterol. He had a bilateral TKR and was correctly prescribed the preventative dose of Eliquis 2.5 milligrams BD on the 13th of the 4th, 2021. On the 3rd of the 5th, 2021, he was diagnosed with a thrombosis in the perineal vein, starting 9 centimetres below the popliteal crease, the knee crease, and extending for 9 centimetres. There was also an 11 centimetre DVT in the cilial vein, commencing 11 centimetres below the popliteal crease. He was changed over to Eliquis 5 milligrams BD, which is half the DVT treatment dose recommended in Australian guidelines, such as the AMH, which does not differentiate between treatments for a distal or a proximal DVT. 3 days later, a follow-up ultrasound showed that the perineal DVT had lengthened by 2 centimetres. The cilial DVT was stable. I communicated these results to the specialist, suggesting an increase to the full treatment dose of Eliquis 10 milligrams BD for 7 days, then 5 milligrams BD with an ultrasound review. This was done, and the patient was subsequently discharged uneventfully. The VMO's original concerns about increasing the anticoagulant dose centred on the risk of bleeding versus benefit of using a full DVT treatment dose and the likelihood of a distal DVT propagation. So, how serious is the bleeding risk and what is the likelihood of a DVT propagation? It is reported that the propagation of a distal DVT into the popliteal vein is approximately 9%, and the related PE rate is almost 1.5%. Should a more proactive prescribing approach be adopted, given that the mortality rate from a PE is 3.9% at 1 month? Or is the incidence of a major bleed of up to 2.1% in patients treated with anticoagulants sufficient to preclude a more proactive treatment approach? These are challenging questions, but the fact that distal DVT was growing while the patient was receiving a low DVT dose forced the decision in favour of the higher DVT treatment dose. Case number 3. Mrs. DM, aged 54, had a total knee replacement on the 20th of the 4th, 2021. She had a past medical history of DVT associated with her 2 prior surgeries. Her haematologist had stated she should be on Xarelto 20 milligrams for life. Instead, her post-TKR was started at the standard dose of Clexane 40 milligrams. Her first scan on the 28th of the 4th, 2021 was negative. On the 3rd of the 5th, 2021, I notified the VMO about the haematologist's view, and the patient was changed back to Xarelto 20 milligrams. However, on the 5th of the 5th, 2021, her follow-up ultrasound revealed a thrombosis in the femoral, popliteal, tibial, and peroneal veins. The thrombosis extended 15 centimetres above the knee and 23 centimetres below the knee crease. Thus, the DVT was 38 centimetres in total length. Xarelto 20 milligrams was stopped and she was changed onto the full DVT treatment dose of Xarelto 15 milligrams BD for 3 weeks, then Xarelto 20 milligrams for life. This error occurred because her clinical history had not been fully and properly reviewed. Case number 4. Mrs. ML, aged 55, had a total knee replacement. She was given Clexane 40 milligrams post-operatively. She had a BMI of 42.7, which placed her in the morbidly obese range, and obesity is a known risk factor for venous thromboembolism. Because her weight was 119 kilos, I suggested a dose of Clexane 60 milligrams daily to the VMO, based on the 0.5 milligram per kilogram per day schedule as reported by Rondina. He requested the research paper, and at our next case conference, we discussed this matter. He was concerned about an increased dose precipitating a cerebral bleed, and I suggested that an anti-factor XA level can be taken after 24 hours to determine if the dose is supratherapeutic, as the steady state of Clexane occurs within 24 hours. He accepted this advice and will enact it when he next has a morbidly obese patient. Case number 5. Mrs. VD was aged 84. She had stopped Pradaxa prior to her total hip replacement, THR, and was subsequently placed on Clexane 40 milligrams post-operatively. Whilst this dose is correct for non-AF patients, it is not indicated in AF patients for stroke prevention. I raised this matter with the rehab specialist, who promptly ceased Clexane and recommenced Pradaxa. To conclude, what can we learn from these case reports? The valuable lessons from these case reports are the importance of a positive, collaborative relationship between the hospital pharmacist and the specialist, regular and vigilant reviewing of the patient's charts, with a particular added emphasis on chart reviews in the immediate post-operative period. Thank you very much for your attendance.
Thank you, John, and thank you everyone for listening in. We look forward to bringing you our next HPS in-service webinar. Please stay in touch with the dates on our Knowledge Centre. Thanks for joining us. Thanks, John.
Goodbye.
Bye.